Hey, welcome to the July edition of Peer-to-Peer Academy. Tonight's going to be a really fun chat. I'm joined by three good friends of mine, Dr. Tanner Ferguson, Dr. Nancy Draskovic, and then Dr. Jessica Hults. So today's unique. What we're trying to do is go through different cases. I mean, what we know about the light adjustable lens is that no two patients are the same. There is just several different ways to take advantage of this awesome technology. And we want to go through different cases where things maybe they didn't go exactly according to plan, and how we kind of got to a good spot. So first up, Tanner, why don't you take it away? Tanner practices in Sioux Falls, in Sioux City, with Vance Thompson Vision. Tanner, why don't you tell us a little bit about yourself, and then let's get into the case and talk about how things went.
Sure. So as Nick mentioned, I practice both in Sioux Falls, South Dakota, and then an hour south of there in the Sioux City area, which is actually a tri-state area that borders on Iowa, South Dakota, and Nebraska. And I'm a cornea, cataract, refractive, and glaucoma surgeon. And I love the light adjustable lens. And this first case I'm going to share kind of highlights or kind of raises the question of um, how do you approach somebody who's got higher magnitude of astigmatism when you really are hoping to reach for the light adjustable lens? And so I'll start with this case. And so this was a 65-year-old female. She's got no history of refractive surgery and has a history of long-term monovision RGP contact lens wear, and she loves it. So distance in the right eye, left eye, near targeted for about a minus 1.5 in her contacts. And she's a moderate myo, but does have 2 bucks a in each eye and has real cataracts, and importantly, dilates well. And she's a motivated patient. She's really hoping for freedom from glasses and an opportunity to emulate what she achieves in contact lenses. And so most of her imaging was unremarkable, clean OCT macula, OCT RNFL, unremarkable. But what drew my attention was on her Penacam, she's got 3 to 3.5 bucks of with the rule sill in both eyes. And so, when we think about LAL, we, kind of the conservative cutoff is it can correct about up to approximately 2 diopters of astigmatism through light treatments. Although I've pushed it before, and I think most of us would agree that you can get more of that than more than 2 diopters through adjustments. But 3.5 bucks of corneal sill is more than I feel comfortable with just using the LAL. And so in this case, and I have some questions laid in here, but I think I'll maybe ask them of the group after the case. I'll just kind of go through the case here first. So in this case, I did a femtosecond astigmatic keratotomy, or AK, plus LAL. And I did that AK at the time of surgery to kind of dampen some of that sill, to make her more functional prior to the adjustment process, but also allow us to kind of fully correct that astigmatism. And so our plan was we'd wait at least 6 weeks for adjustments. I kind of approached this patient like a post-refractive patient, where we kind of let that cornea settle down before we try and start the adjustment process. Then, of course, also wait for a stable refraction. And I discussed with this patient, like I do with most, that because we targeted plano at the gate, that you're for sure going to need your readers prior to adjustments. And then, of course, reminded them of the UV protective eyewear and the kind of the adjustment process. And so waiting about this was actually 6 weeks post-operative. She felt like distance was good, but she was ready for some better near vision. In her dominant eye, she was relatively happy, 20/25, and then 20/40 plus in her non-dominant eye, which is attributable to some residual sill there. So she was like a plus 75, minus 75 in the right eye. But importantly, she was correctable to a 20/15, and she was happy with that 20/15. One thing that, when I'm adjusting a patient, and I perform my own refractions at one site, and then I also work with an optometrist at another site. But when I'm doing the refractions, one thing I like to do, in addition to having them, target a line of vision, is asking them, do you like that vision? Kind of chasing image quality in addition to, chasing the 20/20 or 20/15 line. And she liked the image quality. And so that's why I felt good about this initial target. So we targeted plano in the right eye, minus 75 in the left. And she came back for her second adjustment 2 weeks later, was really happy with how her near eye turned out in her left eye. She was 20/25 plus and J1. She ended up a little bit more myopic than we were targeting, but she was super happy. But she felt like things in the right eye were still a little fuzzy, even though she was, 20/20 minus 3 uncorrected. And it turned out she had some residuals still there. So we performed another adjustment in the right eye targeting plano. And she ended up doing super, super well. Ended up 2015 in her dominant eye, 2025 minus and J1 in her non-dominant eye with a target at -1 sphere. And so, of course, when the patients come back like this, especially when they're, a history of monovision contact lens wear, we, move to lock-in. And so the questions I would have is two, I think, why not do a toric lens in this case? And so maybe that's a question you guys want to ask, or I have an answer myself.
So, I mean, for me, I look at that as an LAL all day, and obviously we're here to talk about the LAL, but you could do a toric. I think in our clinic, it's going to be mostly financially driven. LALs are a little more expensive, torics a little bit cheaper. I mean, a toric, I don't know off the top of my head exactly what the percentage is, but they can rotate. And a high sill case like that, the smaller the rotation, the bigger the impact is going to be. So you really want to be dead on axis. And then you lose the ability to customize. I mean, the LAL in theory is a monofocal lens, but I think calling it a monofocal lens is really doing it a disservice because it does have that extra negative spherical aberration that can broaden the depth of focus. And you have the ability to broaden the depth of focus with the light adjustment. So you don't have that with a toric. So if you end up at -1 with a toric, a standard monofocal toric, you're not going to be 20/25. You're going to be 20/30 or 20/40. You're going to be much more compromised at distance. Anybody else have any thoughts on that?
Yeah, I'm with you completely, Nick. Just how it broadens that depth of focus and how you can get just as good of near without sacrificing as much distance. So, in the patient's left eye, they ended up at a -1. And originally with their monovision, you were mentioning how it was like a -150. So ended up at a less nearsighted target, but with better distance and still really good near vision. So overall, just an awesome outcome. I love the lat adjust lens for monovision patients just because of that better depth perception. I feel like they do a lot better at computer too for like extended periods of time and just the improved distance vision and enhanced distance vision.
No,
What
and
about
I
you, Nancy? Any
agree.
thoughts?
No, I agree. I think the fact that this was a previous successful monovision patient, this is like a home run for LAL patients. You've got the customization that you can do post-operatively, and it's just a win-win across the board.
I want to use this
Yeah.
as a reminder too for everybody watching. Put questions into the chat. I mean, we want this to be interactive as much as possible. So use that chat and let's get involved. Tanner, I got a question for you.
Yeah.
With it was a RGP wear. How long were they wearing RGPs for? How many years, decades?
Decades. And so to answer my own question, why not toric here? This will kind of tie in the answer to your question. If this patient came in, they were, high sill, no history of monovision contact lens wear, and they just wanted really good distance vision, I think toric's a very, great option here. But whenever somebody is a monovision contact lens wearer, I always try and grab or push, reach toward LAL because as you already alluded to in your own answers, I think we know where somebody's near vision should be, but I think it's really hard to, measure how much depth of focus somebody's natural lens has, even when they have a little bit of a cataract. And so as, Jessica mentioned, this patient ended up -1 when they previously wearing a -1.5 contact. And I think sometimes people want, we think we know where they're going to be near, but it's so nice to have that adjustable piece with the LAL. So you can kind of really fine tune that near eye. And then to your point, Nick, I feel like when patients come in with a history of RGP wear, they're never out of contacts as much as we want them to be. And I think it's really hard to ask somebody who's been wearing RGP contact lenses to have them not wear them for, 1 to 2 months, best case scenario. And that's another reason why I love LAL in these patients because, you can kind of overcome the less than ideal measurements you get in these patients because, as I mentioned, they're never out of their contacts as long as we want them to be. And I don't remember the specifics of how long this patient had worn RGPs, but I'm guessing it was 20 to 25 years, probably longer.
Yeah, it's a long time. I mean, in our practice, and there's no real cut line on how long you need to be out, but it's in general guideline one week per decade of wear is kind of how we do
Right.
it. But even that is a bit of an educated guess. I mean, I've had patients where their cornea continues to change. And even, a lot of our patients have been in contacts or hard contacts for 30, 40 years, when in reality, it's maybe closer to 60 or 70 years. Or, they're just inaccurate with what they're telling us. So it's
Hmm.
an educated guess on a poor metric anyways. So for these patients in particular, I always set the expectation that we may need to delay the treatments. We're not really restricted on a certain timeline here. We can always delay, and delay is for the best. We can push off to let your cornea continue to change. And if it does, it's kind of like golfing, right? I use that analogy all the time where the ball is moving around on the green. Let it come to a rest. You may be on a really wonky green and the ball's moving around constantly. Let it come to a rest. So yeah, great case. I love that. Another question for you, Tanner. With the AKs, when
Hmm.
you dial in the AKs as your calculations, are you targeting zero astigmatism or are you trying to leave a little bit left?
I'm not targeting zero astigmatism, so I'm not overly aggressive,
Okay.
knowing that we'll adjust some. I like to, and this is probably influenced by Vance. I like to just do one AK, just preserving the option for having. I think it's easier to make a LASIK flap if for some reason you need to do that down the road if you only perform one AK. So I'm not typically targeting zero astigmatism with a single AK.
Yeah, that can get kind of aggressive. I mean, we usually do. We'll try to target, basically cut the sill in half. So, like for somebody like this
Hmm.
with a 3 or 3.5, if we can leave them with a buck or a buck and a half, that's kind of ideal. That's well
Yeah,
within
I
the range
agree.
of the LAL, and then you got enough room to go up and down. And again, with this patient with the RGP, where you might have to go up or down, so if you can preserve some of that, that's ideal and I think super advantageous. So, how long did it take for this patient to get all the way to the end? Then was this? Did you delay it? I know you said I think 6 weeks
We
you had
started
it.
adjustments about 6 weeks. So I didn't add any further delay than that, even though she had a history of RGP. We started at 6 weeks because whenever I do an AK at the time of cataract with these LAL patients, I typically have them come back at 6 weeks for their first adjustment visit, as opposed to the typical 4 weeks in our practice.
Gotcha. Great case. Great case. Anybody else have any questions? Any comments? All good. Cool. Let's move on. Nancy, why don't you introduce yourself here a little bit and tell us about yourself. Tell us your history and story about the LAL, and then let's get into this fun case you got.
Alrighty. So let me see if I can pull up this quickly first. Sorry.
I like your golf analogy. Man, I'm gonna have to steal that.
I speak in sports analogies all the time. My wife hates it. I drive her nuts. But yeah, sports analogies, baseball, basketball, golf. Yeah, I got them.
Alrighty. I can't find. Do you guys see my screen there?
No.
No.
Not yet.
Okay. Hold on. It's coming.
There
There
you
we
go.
go.
Yeah, now.
Got it.
Let's get this out of the way. Alrighty. Are we on? We're on.
We're on.
Yes.
Go back to the start. So yes, after all of that confusion, here I am, Nancy Draskovic. I'm the clinical director of ocular surface disease at Sullivan Eye Physicians and Surgeons in Bowie, Maryland. We're in the DC area. I live in Virginia, work in Maryland. We do have two locations. Both our main office is in Bowie. We have a secondary location in Greenbelt. We're just a large group MD, OD practice, practice just medical optometry. And, I started 2019 is when we did our first LAL case. Like I said, I think we were the first on the East Coast that did LALs. I was the first OD on the East Coast that actually did light treatments. It kind of started really getting into it in 2020 once the world opened up again after COVID. My case. So this case here is kind of an interesting case that I really enjoyed. It was very complicated, but we're calling it a complex visual rehabilitation in post-RK patient. So this was an LAL patient that was actually a 70-year-old retired female optometrist, which made things extra exciting. So her history here was positive for RK surgery in 1993. She had 8 radial incisions as well as 2 limbal relaxing incisions in each eye. She had previously had bilateral horseshoe retinal tear repair in 2011. Late 2024 is when she had cataract surgery, and we chose to do an RX site light adjustable lens. Her ocular history is also positive just for severe dry eye. She was a glaucoma suspect. And then during her journey post-operatively, she did experience some persistent iritis, which we'll kind of review some of that. Pre-surgery data. So a little bit of myopia. She had about 2.25 diopters of SIL in her right eye, best corrected to 20/40 pre-surgery. The left eye, she had about 1.5 diopters of myopia and 3 diopters of SIL, and best corrected to 20/50. Her case kind of matched this. She has almost 2 diopters of corneal astigmatism preoperatively and 2.5 diopters of astigmatism in her K readings. And our goal was just to give her some functional vision with LAL customization. She has high SIL. We were trying to manage that, her corneal instability because of her previous RK, as well as treating her dry eyes, which were actually quite severe.
So it's 34 diopter flat case.
Yes.
Oof.
Yes.
To deal with that. Sorry, carry on.
That's okay. So, persistent iritis, which we'll be dealing with, these are some complications we ran into, delayed our light treatments, her severe dry eye, which created a lot of fluctuations. And that was really the biggest challenge in this case. And so our goal was just to kind of, deal with that instability of the RK, of the tear film, as well as the postoperative inflammation. We had her on a pretty hefty regimen for her dry eyes. She was taking Cequa twice a day, preservative-free artificial tears 4 times a day, Mibo 4 times a day. We were really trying to do everything we could to stabilize the tear film. So she was always wearing glasses. She wasn't a contact lens wearer because she couldn't tolerate contact lenses because of her surface disease. So the interesting thing actually with this patient, because she was a retired optometrist, she also had a full examination lane in her office, which was a blessing and a curse, more of a blessing, I think, in this case, because she was constantly refracting herself and understood the fluctuations. And so it wasn't me just telling her that she had to follow the protocols. She was seeing it on a daily basis. But she came in, for a 3-week post-op refraction and possible light treatment. And so she ended up presenting with some persistent iritis. So we kind of held off on treating her, wanted to make sure we treated the inflammation first. So we increased her prednisone to QID, and I had her maintain the prednisone until she returned in a couple weeks. But, post-surgical, that first real refraction. So she's got a little bit of hyperopia, about a diopter and 3/4 worth of astigmatism in both eyes. But, remarkably, she was correcting to 20/20 in both eyes. So that was great. She returned a couple weeks later. And so her iritis was resolved. So I started her on a taper of her prednisone. But I told her I wanted her to maintain it at a BID dosing just to give her a little extra help there with her ocular surface dryness and to help stabilize the tear film there. Her refraction here was about 1/4 diopter of hyperopia, 2.25 diopters of SIL in that right eye, and she was correcting to 20/20. The left eye, about 3/4 diopter of hyperopia and 2 diopters of SIL, and she was correcting to 20/20 minus. So we did initiate her first LDD treatment at that visit. Our target was plano in the right eye and a -1 with monovision in the left eye. She ended up coming back 3 weeks later. She had some family medical issues, which kind of delayed her follow-up visits, and that kind of slowed her progress here. She came in, she was seeing 20/20 minus in the right eye, 20/70 in the left eye. And we're kind of getting closer to our target. We kind of knocked out the astigmatism in the right eye. She had a little bit of myopia left over and, still a little bit of astigmatism in the left eye there. So we proceeded with a second LDD treatment to try and achieve our plano in the right eye and -1 in the left eye target. A week later, she came in. She said she was happy with her right eye. Left eye, not quite there. She had, after that last light treatment, stopped all of her dry eye treatments. So we kind of had a little bit of instability here. She wasn't seeing as well as she'd like. She was self-refracting herself and on the daily noticing fluctuations in that refraction as well. So once again, stopped, didn't do any treatments, put a pause on everything, and really stressed compliance with her dry eye regimen. A week later, she comes back, she's compliant and happy. So right eye was great. Left eye, she wanted a little bit of a tweak there, wanted to knock out a little bit more of that astigmatism that she had. But because she was in a happy place in the right eye, we did decide to lock in the first eye or the right eye, and then gave her a tertiary treatment in her left eye. So she didn't come in for 3 weeks again. Family issues that were happening. And she complained that her right eye after that lock-in wasn't as good as it was prior to the lock-in. She was still using her Cequa, but she had kind of stopped everything else. So she didn't use any artificial tears, wasn't using Mibo. She was using, she said she was using them PRN. And then her prednisone, she had stopped altogether. This also happened to be timed with the dead of winter when, dryness is at its peak, and that was exacerbating her dry eyes as well as creating more of that instability. So once again, we put a pause on treatments and come on back. Because of family issues, once again, we didn't see her for 2 months. So during that time, because of her family issues, she really kind of fell off on her dry eye regimen, came down to just Cequa once a day, pred maybe every other day, kind of artificial tears, stopped her Mibo altogether, and her refraction was just all over the place. So another pause, another compliance talk, and we moved on. So comes back a week later, compliant and happy. So a common theme here, when she's compliant, she's good. When she's not compliant with her dry eye regimen, she's all over the place and notices the fluctuations. But she was great. She was happy. She was loving life, but then was nervous about locking in because her philosophy was, well, what if we can make it better? And so I think this was the key where, we talk about this as a collaboration with patients where we're working together, with this team approach. And I kind of felt at this point, I had to just kind of take the reins and say, all right, look at where we started. Look at your scenario. You are a post-RK patient. You've had retinal detachment repairs. You've got severe dry eye. You're seeing 20/20. We didn't know that this was even going to be an option for you. And at this point, what do you not have that you wanted? We achieved her monovision that she was happy with. And so finally she was like, okay, you're right. And I think it's just hard to kind of pull that trigger. And the more knowledge that you have, I think sometimes complicates things a lot more. I think, we could all say that we'd probably be terrible patients when it comes to this because, we have too much of an opinion. But, I sat back and I was like, listen, I think we've achieved everything we wanted to do. And she agreed. And then we moved forward. We did her second lock-in in the right eye, first lock-in in the right eye, first lock-in in the left eye. She returned a week later, was thrilled. She's seen 20/20 in the right eye, 20/30 in the left eye. She was reading J2 at near. She was thrilled with that. We did her final lock-in. And, a lot of keys in this case, this was definitely a long drawn out case. They typically don't last this long, but, there was no reason to be rushing this case. We needed to properly time this to get the best possible outcome for her, making sure that her family life was in order, making sure that her compliance with her dry eyes was in order, so we could get that perfect customization with the light treatments. This is a huge example of how you have to really be treating that ocular surface, because when you're not, there's so many fluctuations that does impact the results. And then that patient engagement, I think that's so crucial here. You need the patient to be compliant with follow-ups, whether it's the post-operative regimen, and just understand that this is a process. This took, we did 23 weeks. So this was almost a 6-month journey that we were on together. But in the end, everyone was happy. So, team-based, that's a big thing that we always want to stress. Don't rush the LAL treatments. Wait until you stabilize. look out for inflammation because inflammation can definitely impact your results. And then, optimizing the surface. And, one of the things that we do in our practice, and I'm sure across the board, is, we're treating the dry eyes aggressively before surgery, during surgery, or, during the first post-operative period, as well as, long term there. And that's really crucial.
Wow, that's awesome. You've got so many pearls in there. I think so many huge key points. I think, if nothing else, this case definitely delivers the idea that there's a psychological component to this process, especially working with an optometrist who presumably has some knowledge of high level optics, right? Nancy, have you gotten or have you changed the way you present this to patients? You've been doing this for over 5 years. So how do you explain to a patient that there may be some delays, or do you set those expectations beforehand? Have you changed how you talk about that?
It varies so drastically from patient to patient, but one of the most important things that I stress is the fact that, this is going to be at a minimum a 6-week journey. But every time we need to make another change, we've got to add extra time to this. And, there is no timeline. There's no reason to rush it. And that is something that I do discuss with patients. But, I don't go into much more detail than that. Those patients that were prolonging it, they understand why it's being prolonged, whether it's, persistent inflammation, whether it's, managing the surface disease, whether it's just the patient's own timeline, they're vacationing, they have, other priorities. There's no real, we don't have to have an endpoint to this. The patient, if they're wearing their glasses at all times, their UV protection, we can prolong this as long as they want to prolong it. It's 6 months isn't something that's typical, but it happens every once in a blue moon.
So I'm curious what the rest of the panel thinks too. I know you did CEQA in this case, and I'm assuming you have a kind of standard regimen. Do you have a standard regimen for OSD?
Yes and no, as far as do I have a preferred medication? Not necessarily. My go-to is really what's covered under the patient's insurance. I think anything is better than nothing. I do want to have some sort of dry eye regimen for the patients and artificial tears during the process. This was obviously a little bit more of an extreme case because she had pretty significant dry eye disease, and it, had a significant impact on her post-operative management. But, most patients don't get this aggressive of a treatment. I'm putting them on tears and some sort of, drop of choice. It's either what I have a sample of or what's covered under their insurance. And I think they all fare decently well.
I think that's fair. I think that's the U.S. health system in 2025.
Yeah.
Whatever's covered, something's better than nothing.
Yeah.
Tanner, Jessica, do you guys have any comments on the dry eye component to this?
One of my big takeaways from this case is this patient had, as you mentioned, a lot of complexifiers. The post-RK, history of RD repair, some early intraocular inflammation, but it seemed like largely it was managing her ocular surface. Yeah. And when she, followed your drop, obviously, I think the history of RK probably led you to delaying the adjustments to begin with. But the reason for, pausing the adjustment process was largely because of her ocular surface wasn't great. And I don't, to answer Nick's question, I don't have a specific regimen for managing dry eye in the post-operative period or even perioperative period. I do a lot of punctal plugs in my LAL patients. I also, reach for like a cyclosporin and do a fair amount of Levi, and Mibo when we can get it covered or we have a surplus of samples is a fantastic option. Mm-hmm. But I probably would have approached it the same way you did. And thinking about the time aspect, I think, when people balk at like the adjustment period with LAL that's unique from other lenses, I just think about how you position the decision of a lens at the time of cataract surgery. It's really a decision of how you want to use your eyes for the rest of your life. And so if it means a couple extra visits to help allow you to have a part in how you see and customize your visual outcome, patients get on board pretty quick. And as you mentioned, Nancy, I don't really lay that out ahead of time that we may need to delay the process for specific reasons, but I think it comes down to time is our friend, And before we rush into making a decision, let's give you some more time before we, plug in the numbers and make an adjustment. So I wouldn't have approached this case any different than you did. And I think I think being patient and remembering that time as our friend is a helpful reminder during this process.
Yeah, I just want to piggyback on that too, with time being your friend. I feel like, especially with these RK patients, from what I've seen, definitely giving them that full 6 to 8 weeks after surgery before starting the adjustments. And then, like you did, just extending as much time as you need in between adjustments. And like Tanner mentioned, in a lot of the cases, it was because of the ocular surface. But sometimes for these RK patients, it is a stability issue. So I often will do 2 full weeks in between. And then I do think having the RK patients the same time of day for their adjustment makes a difference too. So I try to do same time of day, 2 weeks in between, and starting their adjustment 6 to 8 weeks after surgery. And I found all those things have really helped. And when in doubt, postpone. It's always better just to make sure you're getting a consistent, stable refraction before you make that adjustment. And this is just proof of that, and how both of you guys stalled the process because she was getting fluctuations. So this is a really great case because it just shows a really challenging patient, being an optometrist who's refracting herself. And then on top of that, just a challenging case with her history and her ocular disease and everything.
And maybe one last final point I'll make is if you are getting to end into LAL, don't make your first patient a retired optometrist who's post-RK.
Yeah, not
definitely not. No.
You start skiing on the green circles. You don't go to the double blacks. This
That's
is a double black. Nancy, I'm curious, did you use her refractions for the treatments, or did you refract her day of when you did the treatments?
So it was a collaboration. So it was just looking at her refractions was more of, do they match up with what you were getting and what we're getting today? And when there was that variability, we would just pause things. And that was the blessing and the curse. The blessing is the fact that she understood, well, I got this. And she would sit there even in our exam room and she was like, do you mind if I just refract myself? I'm like, go right ahead. And she would pull up the 4-opter and start, flipping lenses and would refract herself and would come up with the same refraction that I would get. And then at the same time, which was very different than what she got at home. So it wasn't hard to convince her to pause. It was just a matter of, are we able to, stabilize your vision? And it was more, in this case, I think the obvious thing is this was more, managing her dry eyes more than anything. And when she was compliant, her vision was stable and her prescriptions were stable. And when she wasn't compliant, it wasn't. So.
Yeah, I think doing the refractions, doing them the time of the adjustment and in the same setting, I think is super important. And to Jessica's point, the same time of day, especially in a case like this, you want apples to apples to apples, right? Yeah. You don't want to have different people refract, whether it be an OD or a tech or a surgeon. The same person should be doing that same step, those same processes every single time to get reliable, repeatable data in the same setting. So different room length, that also matters. If you're in a short room, you may need to add an extra quarter versus a long room versus lights on. Lights should always be on. You want the pupil in kind of its more ambient state. You don't want a dilated pupil because you're going to catch asphericities. So just repeatable, I think that's a really good point, Jessica, that you made. Specific time of day is really important. So let's talk about a patient not like that one, but a patient who is maybe more normal. How often do you delay treatments? How often do you find that you do need to take a week off? Often, not often? Anybody?
Well, I think once again, addressing the dry eye, the status of the ocular surface is always the biggest factor there. And just, do things make sense? What was your acuity today? What was it last time? What was the refraction today? What was it last time? And, I think there's an art to refracting and there's also an art to analyzing the information. And if things just don't make sense, wait, put it on pause.
Mm-hmm. Besides that aspect, the other time I like to delay is if somebody is naive to blended vision, because I would say greater than 90% of my LAL patients, I talk to them about the blended vision aspect of it. And so our first target is almost always plano -75 unless they have a known history of monovision, might target closer to -1. And so if they come back from that and they're still kind of adapting, they think they overall seem happy, but they're thinking, I'm just not sure how this is going so far. And before I, do another adjustment or give them back their distance in both eyes, those are instances where I do delay and say, let's give you some more time to adapt and see if things get better for you. And almost always they come back and they're like, I love it.
It's actually interesting you guys mention all those points, because that leads me into my case a little bit, because I delay for both of those reasons as well.
Why don't we jump into it? Go ahead.
Okay.
Jess, why don't you introduce yourself first and then give us your case?
Of course. So I'm Jessica Hults. I work at Eye Surgeons of Indiana at an OD-MD referral practice similar to Nancy, where it's highly diseased and then also heavy on cataract surgery. So I will share my screen here. And this is like we were talking about, actually just talking about how it can be challenging sometimes with patients who have no history of monovision adapting to the blended vision with the LAL plus. So this is just a standard LAL plus case of someone who has some difficulty adapting to that difference throughout the adjustment process. So at her cataract consultation here, as you can see, she was a 72-year-old female, wears progressive glasses mostly just for driving and for reading, has a history of contacts 40 years ago, but no history of monovision, red eye dominant. Her main complaint was blurry vision and glare halos at nighttime, her left eye more than her right eye. She wanted as much glasses independence as possible, but didn't want the nighttime issues like halos that she was having currently. So as you can see from her spec RX, mostly just some very mild astigmatism. Her uncorrected vision to start with, even with her cataracts, was 20/20 -2 J7 in her right eye and 20/30 +2 J10 in her left eye. So already this is, I can tell, going to be a challenging patient because she really doesn't have much of a prescription, only really wears glasses for driving and for reading. So from the beginning, this is someone definitely you want to set up expectations at the beginning that there is going to be some difference between the eyes or some type of offset mini monovision or blended vision in order to gain that range of vision. But she was excited about this process as it was customizable and you didn't get the nighttime complaints that you get with the multifocal implants. So we decided to proceed with LAL plus. So she returned for her first visit. Her right eye was 20/25 -2 J10 and her left eye 20/30 +1 J16. Manifesting +1/4, +50 axis 90, and +50 diopter sphere. And talked through blended vision. Patient decided she wanted to proceed. Typically for LAL plus, I'll target like plano -75 and -1. So for her, we decided to go plano -1 at her first visit. Visit 2, when she came in her right eye, she was 20/15 -2 J5. But I wanted to highlight some key things that she mentioned, that she was getting fluctuations with her vision when she was blinking. And then in her left eye, she's 20/30 -2 J5, but wanted to highlight that she mentioned her distance vision was worse than before surgery. So that comment always highlights for me, because her vision prior to surgery was 20/30 +2. So she lost about a line or less, but complaining it's so much worse than before surgery. When I get those exaggerated complaints that don't necessarily line up with their vision, I am immediately thinking this patient's probably going to need more time to adapt. And then in her right eye, her vision fluctuating with blinking, there's definitely a dry eye component here. And as we know, when dry eyes flared up, that can flare up everything, can make adaptation more difficult, can just make them feel like nothing's crisp or clear. So we decided to postpone at this visit due to the reasons we were just talking about: dryness, needing more time to adapt. And then when I was looking at her under the slit lamp, she did have some very mild PCO. At this point, I didn't quite YAG. I wanted to give her a little more time just because there were these other components. So I had her increase the tears to every 2 hours. We have all of our patients on preservative-free artificial tears 4 times a day before they come in for their adjustments. So typically I'll increase them to like every 2 hours and add a steroid if we end up having to postpone because of dryness. And then she returned at her third visit. Her right eye no longer complaining of the fluctuations. She's 20/15 -1 J5. And then her left eye, her vision, you can see distance decreased the line, but her near improved. She said her distance vision was tolerable, even though it got a little worse. That's telling me she's adapting and that her near is getting better. She's adapting because we didn't do any adjustment other than we did improve her dry eye treatment. So that was contributing to it as well. At this visit, this is where you can do a couple different things. You can continue to delay, give her some more time to continue to adapt. You can also do loose trial lenses, or in some cases, if I'm having a hard time really dialing in what the patient wants or needs, you can also trial contact lenses with like the referring optometrist or an optometrist in the community. Or if you have the ability to do that in your office, you can do that as well. This patient's case, because we were seeing improvement, I didn't feel like we needed to delay another week. I decided to do loose lenses, and based on her response to loose lenses in the office, was going to decide if we needed to trial contact lenses. So with this patient, we trialed -1 because I was actually manifesting her at -75, even though I targeted -1. So I showed her -1, -1.25, and -150. And of course, she wanted all that mirror she could get. So she wanted the one -150, but I was nervous with her just because of her issues with adaptation. I don't like to go to a one diopter adjustment and one adjustment, especially for someone who's having difficulties with adaptation. So I said, let's stop at -1.5, see how you do with this when you return. And then if you want to dial in more near at the follow-up, we can, especially given she have a history of monovision. For the right eye, just decided to postpone, wait till the left eye was ready and just focus on dry eye in the eye. So she returned visit 4. At this visit, her right eye, she was complaining again of it not being crisp, even though we haven't touched that eye with an adjustment in a while, only been doing dry eye treatment. And then in the left eye, she's 20/60 -2, J2 near, but she was saying that she couldn't read road signs until she was on top of them. So again, this was kind of a dramatic quote. That's why I wanted to highlight that from the patient. So again, you're getting these complaints that seem kind of dramatic in comparison to their vision. And so I was like, okay, here's another adaptation issue. Want to give her more time. But since she had adapted in the past, and there still was that PCO, and now she was complaining of the right eye not being crisp, I hadn't touched it. We've been focusing on dry eye, decided to proceed with the YAG in both eyes. And then at visit 5, she returned after she had had the YAG. And her 2 adjustments that we've done throughout the process, and she was happy. She was 20/15 -1 J3 in her right eye, and 20/40 -2 J1 -2 in her left eye, with her manifest at plano right eye -1.25 left eye, and decided to lock in. Then we finished the lock in at visit 6. She was doing really good overall. Final outcome 20/15 -1 in her right eye J3, and then in the left eye -1.25, 20/40 -2, J1 -2, OU 20/20 +2, J1 -2. And this is someone too, when we follow up with her final post-op, she'll probably even be doing even better, both at distance and near, because she's someone that each week kind of got a little bit better, especially her near. She might be able to read the whole J1 or something, because she just is one of those patients, needs a little bit more time to adapt. But she overall did really well. This is someone, though, if she had come back that last visit, let me get back to that. So she'd come back at visit 5 and she was like still not adapting. That would be a point where I would consider referring back to the referring optometrist to trial contact lenses. And the reason I mention this is because I have used this in a fair amount of cases, and I feel like it's been very successful. Patients often get really nervous at the thought of an adjustment or a lock-in in the permanency aspect, that they're using up an adjustment or they're almost to lock in. So contact lenses, being able to trial those, I find patients really like that, because not only are you getting them back with their optometrist that they've had a long established relationship with and they trust, but they're also getting a second opinion from them. They're getting the ability to trial some different aims before they use up that adjustment. And oftentimes will really dial in that exact aim that they want. So that is something I wanted to bring up this case, just because we all run into this every once in a while, where you have someone who doesn't adapt the anisometropia. How I've handled it in the past, and ways that have really helped me. And then also just to get your guys' feedback too, to see what else you guys do and how you guys handle it with cases like this.
That's awesome. Great case. A lot of good nuggets there too. One thing I want to start at the beginning with that, because we had a couple questions come through.
Yeah.
Why LAL plus versus LAL in that case? Anything specific?
So for LAL plus, we'll typically do on patients who don't have any retinopathy, so healthy eyes. So she was healthy overall. She didn't really have any other eye disease other than some mild dry eye and the cataracts. So no issues, no retinopathy, and her topography was normal. So just a really good patient, kind of virgin cornea too, no LASIK or RK or anything. So typically those type of patients, we try to utilize LAL plus just because you will get a little bit better near vision with those patients.
Nancy, Tanner, you guys have any thoughts on LAL versus LAL plus, when to use, when not to use? There's a question specifically about post-refractive patients, avoiding LAL plus in post-refractive patients. Is that what you guys do in your practices, or do you there are cases where you would?
Yeah, so we typically avoid, we kind of tailor the LAL lens specifically to any post-refractive patients. And so I don't think those are the most ideal candidates. They do have more issues with contrast sensitivity, we found. We've had to explant a couple LAL pluses into the standard LAL lens. So definitely not used for any patient that has any sort of corneal ectasia, any previous refractive surgery, definitely not a RK patient. So it's really those virgin eyes that have no, other pathology as well. So we did more LAL pluses previously and now have kind of leaned more towards doing just the standard LAL lenses and just kind of playing with monovision as needed. But there's definitely a few LAL pluses that we do if it's that perfect patient.
Yeah, we have a very similar practice pattern to Nancy, or at least I do. I don't use it in post-refractive eyes, and really it's because I don't feel any need to. I've been so happy with how the LAL performs in that population. I feel like introducing additional aberration, which is that lens, how that lens is designed, doesn't really make sense to me. But I've used it kind of in that mix and match way that others have described, where I do the LAL in the dominant eye and then the LAL plus in the non-dominant eye, trying to minimize a little bit that difference between the two eyes. And I've had success doing it that way. And that's largely how I use it so far. But I've liked it.
I think having an aberrometer is really helpful in those scenarios when you're trying to decide whether to do LAL versus LAL plus. I mean, as a rule, we've adopted the same philosophy you guys have: no LAL plus in post-refractive eyes. Could it be done with success? Yeah, it could. But I think the margins for improvement with the LAL plus versus the LA are pretty slim. And Tanner, to your point, I don't think you really have to. I think the LAL shines in those cases anyways.
Yeah. Right.
In the virgin corneas, in the corneas where things are perfect and the patient is 20/20 or better capable, LAL plus could get you that little extra bit. And it does work very, very well. It does have to be perfectly centered, and you have to, understand the optics of the eye. So again, that's where aberrometry, I think, can help. But as a hard, fast rule, I think, everybody's going to have different opinions on this, but I do think LAL plus, avoiding it in post-refractive, is just safe, and I don't think you really need it. In our practice, we're pretty close to 50/50, maybe more 40/60 LAL plus to LAL. And it's just because we do have a high post-refractive patient base, as everybody does in 2025. The LASIK boom was about 20 years ago, so we're kind of there. Other point, Jessica, with your case, you delayed for a YAG. What's everybody's opinion on YAGs? That's a pretty hot topic, I think, in the LAL world. When to do a YAG, when to avoid it. Does everybody just do it prophylactically? Thoughts?
I definitely am not on the prophylactic train. I basically approach it like if I'm thinking of basically like if I'm approaching it like a patient who's had any type of advanced technology IOL, whether I'm thinking about doing LASIK or an adjustment, if their refraction is not crisp, and I think it's largely attributable to PCO, then I recommend a YAG. But I'm definitely not somebody who believes every patient who has LAL should have a YAG, then do adjustments. But there's actually a recent paper that was just published this past month in JCRS, and they have been doing LAL for 3 years. I think they looked at a study of almost 500 eyes. And they have two groups, patients who had YAGs during adjustments, then also after adjustments. And there's no difference between the two groups in terms of how it impacted refraction. So really just demonstrated that, or was probably confirmatory for things we all believe, that doing a YAG in an LAL patient is refractively neutral. And I feel safe about doing it, whether it's during adjustments, pre-adjustments, or after adjustments.
Yeah. I agree. I mean, I don't think anything comes without risk in medicine, right? So if you don't have to do it, don't just do it on anybody.
Yeah.
If it is impacting the refraction, if your numbers don't make sense, I mean, if 2 + 2 = 9, that's where those cases you got to step back and figure out what's going on. Is it PCO? Is it CME? Is it ocular surface disease? And if it's PCO, take care of it. I have found that the lens is a little bit easier to pit, so you do want to be a little bit careful. It's a silicone lens after all. It's a little bit softer. And we always do a cruciate pattern. We do a circle pattern. We don't do a cruciate. I'm sorry. We don't do cross through the optical center. We do a circle pattern, so you're kind of outside just in case. But when we do YAG, it's fine. Just be careful and understand that nothing comes without risk. But if that's what it takes to get the patient where you want them to be, then that's what you got to do. Jessica, Nancy, any thoughts on YAGs? I mean, you did one in this.
Yeah, we don't do them prophylactically. If it's needed, we'll do it. But other than that, no. When the time comes.
That's the same way for me too. There has to be a reason. So if I can refract them to 20/20, I try to not do it. But in this patient's case, they were refracting to 20/15, but just still complaining of it not being crisp after doing dry eye treatment, and everything else looked normal. So that's what drove me to do the YAG. A lot of times it'll be like central too. So where it's at, if it's very mild, but it's in their visual axis, it'll really make a difference. Sometimes they'll complain of things just being dim, like it's dimmer or like just filmy or not crisp. And that's all you need is just to YAG and it clears it up for them.
I want to go back to a question we had a little bit earlier. Have you guys had any observations of refractive shifts after the lock-in? Anybody had any observations? Because I really haven't. Have you guys noticed anything after the first lock or second lock where the numbers actually changed?
So in my case, the one that I just presented, that was the issue, but it was surface related. It wasn't related to the actual lock-in itself.
Yeah, that's when the question came in, was with your case, yeah. Nancy. I think in your case, your case is a bit of a unicorn because of the RK, and that cornea is going to fluctuate constantly anyway. So the numbers I don't think are, your refractive endpoint is much softer than it would be with a virgin cornea. Sure. I have not noticed changes in virgin corneas. I have not noticed changes. What I do tell patients, especially after the day of the final lock-in, almost expect your vision to be a little fuzzy for a day or two. And that's ocular surface 100%. And so, because I get those phone calls, I used to get those phone calls a lot before I kind of put that into my spiel. Hey, my vision was good yesterday, now it's kind of blurry. Well, that's a lot of UV light. If you go to the beach, you can put all sorts of sunscreen on, but if you spend 3 hours at the beach, you're going to feel a little bit crispy after you leave. The same thing's happening to your cornea. It's much more sensitive. So expect your vision to be just a little bit worse than it is right now, but it will get better. Use your teardrops. We have every patient on a regimen of preservative-free tears at the very least 4 times a day. I tell them don't change anything for a week. You can take your glasses off tomorrow, 24 hours after the lock-in. You could take those glasses off and never think about them ever again. But the tears, at least for a week, if not longer. And then when do you guys follow up with these patients, or do you? How do you communicate with your co-managing network if they're referred in? What the follow-up is after the light treatments?
Yeah, we do a 6 to 8 week follow-up after, because I find that's about the period of time that dry eye can still stay flared up after the final lock-in. So by that point, it's more stable, and they're doing a lot better at that point in regards to the dry eye.
Yeah, we're probably in that similar time frame. Probably at least 8 weeks. Most patients, by the time they get to their lock-in, are sick of seeing eye doctors for a bit. So I think giving them 8 weeks, particularly if they're doing well, is a good time frame.
Yeah, we typically I'll send my patients back to their referring ODs about 3 months out. Yeah, we've seen them, multiple times before then. So I feel pretty comfortable waiting the extra 3 months for them to reset everything again.
Yeah, we give them exactly 2 months. So right in line with you guys. I think 2 months is I mean, things stabilize over a couple weeks. You know, like I said, those first couple weeks are where they're still adapting to it. When I see them back for the 2 month, they're very happy. You know, that they are like, you know, they're by the time we get to the lock-in, you're totally right, Tanner. They're just kind of sick of seeing me. And that's fine. You know, even my wife is sick of seeing me half the time. But they're ready to be done with that process. But when they come back, they're so excited. And that's the fun, that's the best visit because they're like, holy cow, you know, I didn't realize what I was missing. These glasses, you know, I'm done with those. I can see things. And they're almost so proud. It's like my 4-year-old coming home from school and wants to show me a picture. Like, look what I can read. And they're so excited. And 2 months, I think, is appropriate. It kicks things down a little bit. If we need to do some long-term dry eye therapy, if we're putting them on an immunomodulator, it gives it time to really ramp up or just kind of maintain. Vision is such a passive process, but we've asked them to be so critical of their vision for, you know, 6 to 8 weeks or however long it takes. You don't think about breathing, you don't think about walking, but when you start thinking about the breaths that you take, it becomes kind of awkward. And that's how vision is. Sometimes I think with this process, it becomes kind of awkward and they're like very critical of it. And then once you're done, you just go back to normal life. And I think that allows them to just, again, it reaffirms that adaptation process that's still happening.
Yeah, I find that when my patients do come back after having their treatments are done, it's like they're little celebrities because they're like, I told all my friends and they're like, what kind of lens did you have? That's so cool. And, you know, it's still relatively new technology. We know about it, but, you know, the general population doesn't really know much about this lens. And so when you do have patients telling all their family and friends, it's like they think they're, you know, extra bionic because they have this really cool lens that we changed along the way. So that's always exciting to see.
Yeah. Well, Tara, I know you had another case, but I don't think we're going to get through it in 3 minutes. It's probably a little more complicated than the. So maybe we'll save it for next time. But any closing remarks, any other comments to our distinguished panelists? I want to thank you guys again for joining. This was awesome.
Yeah, this is great. And those are great cases, guys.
Okay. This is recorded, so it will be up on the Peer-to-Peer Academy website in a couple of days. If you little tidbits that you missed, hop on there and check it there. Otherwise, keep an eye on your emails. And thanks again, everybody, for joining. Appreciate it.
Thanks so much.
Thanks, Nick.
Thanks, Nick.